Depression rates among Singaporeans have been steadily increasing over the years. Since 2018, depression has been the most common mental health condition in Singapore. It is also highly prevalent amongst youths, with studies showing that depression affects up to 18% of Singaporean youth. COVID-19 has certainly not helped things, with 1 in 3 Singaporeans reporting to be anxious or depressed during the pandemic. So what is depression, and what can we do about it?
Depressed patients may become so desperate that suicide seems to be the only way out.
Nothing interested me.
Nothing interested you.
In the background of all depressions is the risk of suicide.
And it's not just behavioral symptoms. Depression has physical manifestations inside the brain.
There are many different types of depression, and they are collectively known as depressive disorders. Generally, the symptoms of a depressive disorder would include distress or disability resulting from an abnormally negative mood, feelings of hopelessness, loss of appetite, weight and/or enjoyment from activities, or even suicidal thoughts. Different depressive disorders can also have different characteristics. For example, major depression causes a person to be depressed on most days of the week, while bipolar disorder, aka manic depression, causes a person to be extremely cheerful one moment, then suddenly extremely depressed the next. Depression can develop at any age, but studies have placed the median age of onset for different kinds of depression. For instance, the median age of onset for major depressive disorder is 32.5 years. But what causes depression in the first place? Let's look at two major hypotheses for the cause of depression: the monoamine hypothesis and the neuroplasticity and neurogenesis hypothesis. The monoamine hypothesis. This hypothesis involves neurotransmitters, the chemicals our neurons use to communicate with one another. Let us first recall how neurons work. In neurons, a signal is carried as an electrical signal. Before a region called the axon hillock, the signal is a graded potential, and after it, the signal is an action potential. In humans, once the signal reaches the end of the neuron, it is converted into a chemical signal made up of neurotransmitters to transmit the signal to the next neuron. The receiving neuron then converts these chemical signals back to electrical signals. Let us take a closer look at this process. When an action potential reaches the axon terminal, the membrane depolarizes to a certain threshold. This triggers voltage-gated Ca2+ channels to open, causing an influx of Ca2+ ions. They facilitate docking of synaptic vesicles that contain neurotransmitters to the presynaptic membrane. After fusing to the membrane, the vesicles release the neurotransmitters into the synaptic cleft, the space between the two neurons. The neurotransmitters diffuse towards receptors on the postsynaptic membrane and bind to their receptors to cause a conformational change, which leads to the opening of ion channels. If the neurotransmitter is excitatory, it will cause an influx of Na+ ions and result in a graded potential, so the signal is transmitted to the next neuron. Since neurotransmitters can keep binding to receptors as long as they are in the synaptic cleft, there needs to be a way to remove them from the synaptic cleft so that the signal can be stopped. One way this is achieved is the reuptake transporters at the presynaptic neuron's axon terminal, which helps to reuptake the neurotransmitters. There are many neurotransmitters related to depression, but let's focus on the ones that constitute the monoamine hypothesis. The monoamine hypothesis simply states that depression could be caused by the deficiency of monoamine neurotransmitters, which are dopamine, serotonin, and norepinephrine. The first monoamine, dopamine, is heavily involved in creating positive feelings associated with reward or reinforcement that motivate us to continue with a task or activity. Serotonin, meanwhile, is known as a feel-good chemical and helps us regulate our mood, on top of other functions such as blood clotting and sexual arousal. Norepinephrine plays a pivotal role in the fight-or-flight response and works closely with another chemical, adrenaline. So far, research has shown that serotonin levels are inconclusively lower in depressed people, although antidepressant drugs, which block the reuptake transporter for serotonin and cause serotonin buildup in the synaptic cleft, are effective in mitigating depression, possibly because reduced serotonin corresponds to impulsivity rather than depression per se. As for dopamine and norepinephrine, results have not been consistent, but some research suggests that in depressed people, homovanillic acid, closely associated with dopamine levels, were in lower levels, and there are less dopamine reuptake transporters, but more dopamine receptors, suggesting that the brain was responding to lower dopamine transmission. But something that perplexed scientists was that when a person was given antidepressants, which were engineered to boost neurotransmitter levels, the effects only occurred after several weeks. Evidently, the monoamine hypothesis can't be the full picture. Recent research has revealed that another piece of the puzzle lies in the limbic system.
The limbic system controls behaviors associated with emotions such as those aimed at individual survival and those directed towards perpetuating the species. By stimulating specific regions of the limbic system during brain surgery, scientists have been able to produce in the patient joy, satisfaction, or pleasure in one region, and discouragement, fear, or anxiety in another. In other words, the limbic system is the control center of our behavioral and emotional responses. Thanks to brain imaging technology, scientists have identified different parts of the limbic system, such as the amygdala and hippocampus, which may be linked to depression. The amygdala is linked with emotions such as anger, sorrow, fear, pleasure, and sexual arousal. Researchers have found that activity in the amygdala is higher in people who are sad or clinically depressed. The hippocampus has a central role in processing long-term memory and recollection. Together with the amygdala, it's responsible for the once bitten twice shy phenomenon, where one becomes careful or fearful when encountering something dangerous again. Interestingly, research has shown that in depressed individuals, the hippocampus has atrophied. For instance, patients with major depressive disorder show a bilateral reduction in size of the principal hippocampal substructures, the cornu eminence, dentate gyrus, and subiculum. To explain this, scientists propose the neuroplasticity and neurogenesis hypothesis. When faced with stress, the hypothalamus releases corticotropin-releasing hormone, or CRH, which stimulates the pituitary gland to secrete adrenocorticotropic hormone, or ACTH, into the bloodstream. This in turn stimulates the adrenal glands on top of both kidneys to secrete glucocorticoids. Usually, in what's called a negative feedback loop, glucocorticoids will inhibit the hypothalamus and pituitary gland from secreting more CRH and ACTH, preventing more glucocorticoids from being secreted so you don't overdose on glucocorticoids. But in depressed people, this negative feedback loop does not work, so the glucocorticoid levels skyrocket. When this happens, the hippocampus atrophy is due to the death of neurons in the hippocampus and sluggish neurogenesis, or the generation of new neurons. Now we talk about treatment methods. No two people are affected by depression in exactly the same way. There is no one-size-fits-all treatment to cure depression. The following are the most commonly used modern treatments. Antidepressants. Most of these counter the molecular imbalances in neurotransmitter systems. Examples include selective serotonin reuptake inhibitors, SSRIs, serotonin and norepinephrine reuptake inhibitors, SNRIs, and dopamine reuptake inhibitors. These inhibit the reuptake of serotonin, norepinephrine, and dopamine respectively. They effectively reduce the symptoms of neurotransmitter deficiency by prolonging the activity and thus effects of their corresponding neurotransmitters. SSRIs are the most commonly prescribed due to their general effectiveness in most cases and their fewer side effects. As SSRIs are known to be highly selective and only affect serotonin reuptake, this might indicate that the majority of mood disorders and major depression are due to serotonin deficiency. In addition, there are monoamine oxidase inhibitors. These inhibit monoamine oxidase. Remember the monoamine hypothesis, and that serotonin, dopamine, and norepinephrine are monoamines? As the name implies, monoamine oxidase oxidizes and breaks down such monoamines. As such, it is a contributor to monoamine deficiency. Monoamine oxidase inhibitors inhibit this, thus allowing for prolonged neurotransmitter effects. While it may seem that monoamine oxidase inhibitors are great because they are able to combat several neurotransmitter deficiencies, they are usually used only if SSRIs or other antidepressants have not worked because monoamine oxidase inhibitors may cause side effects when consumed at the same time as other medications and some foods. The obvious drawback of neurotransmitter supplements is that often, patients do not need all of them. In fact, there is pretty much no way to diagnose exactly which receptor or which neurotransmitter is malfunctioning in which way. Hence, antidepressants are prescribed for a period of 6 or so weeks. In some cases, a low initial dose is prescribed so that the side effects are minimized. If no effects are observed after a period of time, either the drug or the dose is changed. As most of us know, therapy for depression exists and can be very helpful. Depression has more than genetic, biological, and chemical causes. Therapy such as behavioral therapy also helps patients cope with negative emotions or recognize sources of negative emotion and then deal with those. In conclusion, depression is a complex disease that results from more than hormonal imbalance. Nevertheless, there are things that we can do to mitigate depression, like therapy and taking antidepressants. Moreover, science will continue to help us refine how we understand and treat depression. Perhaps you could also one day join in to unravel the mysteries behind depression.
That's not true. Kinda.